Welcome back, ladies and gentlemen. We'll now be moving on to the third symposium on airway disease. I now invite the chairpersons, consultant respiratory physician, Dr. Amit Fernando, and consultant physician, Dr. Upul Disanayake, president of the Ceylon College of Physicians, to introduce the speakers.
Good morning. We have this symposium on airway diseases. We have an interesting line of talks and eminent panel of speakers to address us. It's my pleasant task to invite Dr. Deepak Talva from India, senior consultant respiratory physician, to talk on his topic of heterogeneity in COPD, which is a topic of current interest.
Thank you, respected chairpersons, as well as organizers for this Sri Lanka Pulmonologist Annual Conference, RESPIRE, my friends. And when I met a lot of people in the morning today, so they were saying that, how do you feel when you're going to talk about COPD rather than your topic, which is like biologicals and ILDs and things like that? I said, the entire gamut is changing, and I think that's the precise reason where so nicely, I think, titled talk which talks about heterogeneity in COPD and its clinical implications makes definitely a lot of sense today, because we are definitely moving where we need to move, and I think there are people who are taking immense strides in that. And in next couple of slides, I'll tell you why it has become so important and what we can have or what we can do as far as in our clinical practice it is concerned. We all understand that we have almost 500 million COPD patients, and in my earlier interactions in this place, I have interacted with you people that it's as bad as India. COPD is very, very rampant, where every second death which happens is because of chronic obstructive pulmonary disease. And all these years with these numbers and this kind of a disease, we are talking about improving their symptoms, improving their quality of life. And perhaps there is a very significant limitation when it comes to talk about mortality reduction. Is there a disease, a chronic disease, in which we do not talk about longevity? I think we definitely want longevity, but we do realize that this disease is such a chronic disease, progressive disease, which does not give much room to improve on the longevity aspect, or what we call as survival. So if you look at GOLD 2024, it clearly uses the word, which is the title of my talk, heterogeneity. Lung is a heterogeneous condition, and after almost about 25 years, the GOLD has realized to utilize this term in COPD also, and earlier it was used in GIN also. So we know that airway diseases are heterogeneous, and COPD is no different. It is also heterogeneous because one COPD patient looks totally different from another COPD patient, not in the looks, but in the behavior. What troubles a COPD patient, number 1, may not do it for number 2, may not do it for number 10, and every patient will have its own peculiarities, and that is perhaps what we need to account for in a disease which is characterized by mainly the 3 domains which have been defined by GOLD. One is, of course, the respiratory symptoms and exacerbations. Second is presence of abnormalities in the airways as well as the alveoli. And of course, airflow limitation will never go away, because that's the third pillar when we talk about COPD. But you can see itself, there are so many heterogeneities expressed in this definition of COPD itself. There may be patients who may have very little symptoms, different respiratory symptoms, exacerbations, no exacerbations. Airflow limitations may be severe, moderately severe, very severe, and new entities which are called PRISM, where you have only FVC and FEV1 low, but the ratios are still preserved. So that's the kind of scenario which even exists in the backbone of the diagnosis of COPD, which is airflow limitation. And then, of course, finally, we have moved on, that it's not only the airway disease, but there are also alveolar abnormalities, and obviously they can not all of them be dealt in a similar manner, or one treatment which is going to cater to each and every patient, realizing this, that there is a heterogeneity, and it has been endorsed by 2024 Gold. So if you look at it, upfront treatment of COPD or the follow-up treatment of COPD, and what you are left with in 2024 blissfully is just two choices predominantly, either a dual therapy, which is lavaloma, or a triple therapy, which is add-on ICS to your dual therapy. And the important aspect which we are going to talk about today is this heterogeneity. Will all COPD patients do good when they are treated with either dual or triple therapy? And the difference between dual and triple therapy is only related to exacerbations which do respond to inhaled corticosteroids. So that's the only two domains which are there in this heterogeneity. But then I think the important aspect is the current management of these two options need to change, and to realize that ultimately our COPD patients are not dying of COPD. In fact, more than 2/3 of patients die of non-respiratory causes. Many a times you can tell them that even if you have an FEV1 of 20%, you may live for 20 years, but if you have a coronary artery disease, you are going to die next very day. So these are the kind of things which cannot be explained by one concept of COPD being one bundle of disease. And of course, there brings the heterogeneity. Now, I will just quickly finish off this slide that when do you use inhaled corticosteroid? You use inhaled corticosteroids in the group of patients who are exacerbating, despite being given dual bronchodilator therapy. And this is the review of systemic meta-analysis, which Professor Wells was talking about in the morning, that we do a lot of reviews of this systemic meta-analysis also, which shows clearly that there is about 27% additional reduction in exacerbations, but also the first signs, the signal, which is coming up, reduction in mortality. So you can see that about 1/3 reduction in mortality related to reduction in exacerbation perhaps, but then now we are talking about reduction in mortality in COPD patients, adding longevity to their lives. But it ends all there because that's what the triple therapy is. What do you do beyond that? And the question which comes to mind is, why not able to control all exacerbations in COPD? And answer would be that all exacerbations in COPD are not same. Some of them are infective, some of them are inflammatory, some of them are allergic, some of them are related to pollution, some of them are related to exposures due to the industry. So how can all of them be treated by a single approach of looking after their exacerbations? And if you look at this picture, it tells you that exacerbations is contributed by many, many factors. And unless and until you account for these factors, the treatment and the response was going to be grossly inadequate. The second part of the presentation is also important, that the quality of life and dyspnea, the two other, the pillars of COPD sufferings, which we are trying to address, are not only related to or corresponding to lung functions. We have been targeting lung functions by dual bronchodilators and exacerbations by adding inhaled corticosteroids. But is the patient's dyspnea and a quality of life only related to this? And if not, then what are the other causes? And you can look at the list of causes which contribute to dyspnea and the list of causes which contribute to poor quality of life in COPD patients. And many of them are related to dyspnea, the quality of life poor because of depression, disability, cardiovascular disease, arthritis, many things which do not are outside the domain of the respiratory system. And even the dyspnea is not only the airflow limitation on lung functions, but patients' weight loss, myopathies, and things like sarcopenia, and many other causes of breathlessness contribute to it. So I think in a nutshell, what it means is when we are targeting exacerbation symptoms and quality of life, what we are actually doing is a broad treatment for all of them, but not going deeper into it because there are many causes of it, and hence all of the patients will not respond to that. So treating it with bronchodilators alone or in a combination with inhaled corticosteroids is not sufficient. And that has already come into very clearly in the last decade, that despite all the developments which happened on the field of COPD in this century, the improvements in the lung functions have now almost plateaued. They are not improving any further besides the dual bronchodilators. Exacerbations, despite using inhaled corticosteroids, continue to grow. There is increased exposure to accounts for hospitalizations and expenses. And of course, there is a quality of life which still continues to be poor, and death rates are not declining, which is, I think, the biggest red flag that in COPD, despite making them feel better, we are not able to improve their longevity. So we need to change, and we need to change for better outcomes in patients of COPD in future. And this has to be incorporated in the management of COPD, and that's the term heterogeneity. And this heterogeneity is giving you an opportunity to practice what is called as precision medicine, or the medicine which is based on identifying treatable targets which are present in an individual patient, and base your treatments on those treatable targets and address the all related issues which are about COPD and its heterogeneity. And this is ideally suited because we have already discussed that one kind of a bundle approach in COPD does not work for all of them, because it's a disease which is in continuum with many different diseases, and hence individualized treatment is the way forward in this. And the treatable traits in COPD to treat the heterogeneity is one way forward. It does start with identifying the patient still with airflow limitation, because we do not have a better definition at the moment, but we do understand there are patients of COPD who have normal lung functions. There are patients who do not have airway involvement rather than emphysema predominant patients, and they also need to be treated because they also have COPD. So what we do is we identify traits. What is a trait? So trait is a feature which is present in an individual which can be picked up by a diagnostic test and has a pharmacological or a non-pharmacological treatment available to target that trait. So many of them are treatable, and some of them are not treatable, like genetics. So you will leave behind at the moment, but in future you will look forward to that also. But presently identify treatable targets in these patients and identify them with measurable diagnostic tests, and then treat them aggressively to overall get the global improvement in the patient. And for that reason, these traits are defined into three groups: pulmonary, extrapulmonary, and behavioral or risk factors. So you can see this picture. It looks a little messy, but it is trying to tell you that each trait, whether it is pulmonary, extrapulmonary, or behavioral, it has got many subheadings in it, which are the individual traits in those groups which have been combined together. And to make this look a little simple, you can see pulmonary, besides airflow limitation, you have the two phenotypics, which is chronic bronchitis or emphysema or bronchiectasis, eosinophilic airway inflammation, mucus hypersecretion, airway colonization, precapillary pulmonary hypertension, and patients who do develop chronic respiratory failure. You have extrapulmonary traits like osteopenia, dysfunctional breathing, psychiatric disorders, sarcopenia, obesity or deconditioning, comorbidities significant like sleep apnea, cardiovascular disease, gastroesophageal reflux disease, chronic rhinosinusitis, and persistent systemic inflammation. And not to forget the third trait, which is a behavioral or a risk factor trait, which is like related to smoking, exposures, forgetfulness, family support, patients who are poor perceivers, and many patients who are on polypharmacy, and of course, very important and never to forget, suboptimal technique, adherence, and side effects of the medications, which all will complicate the issues when we decide about the management of these diseases. So first trait of pulmonary trait in COPD patients is airflow limitation, and the picture itself shows you that there are many causes of airflow limitation. So how can a one inhaler look after everything? So if it is related to air smooth muscle contraction, which is on the top, yes, you can use bronchodilators, 1 or 2. Whatever you have on board, and now the third one, refivenicin, is also coming up, so you might have 3 bronchodilators to look after that. The second is airway inflammation, which can be picked up either by the exhaled nitric oxide or looking at the airways by other surrogate markers which are available, like blood eosinophils, and they can be targeted by either inhaled corticosteroids and many others which are in the process and pipeline. You can have a decreased elastic recoil causing airway limitation, which can be related to emphysema. And of course, they will have a non-pharmacological treatments like coils and valves and other things, even a lung volume reduction surgery. And then very important aspect of airflow limitation is also mucus plugging and mucus retention in the lungs. And of course, this will require a lot of mucus clearing devices as well as some medications which can improve that. So I think this snapshot picture will give you an idea that simple airflow limitation picked up on spirometry. The diagnostic process is spirometry, but the causes of it could be so many, and then you need to address them by doing other tests to pick up individual cause of airflow limitation. A very important is the sputum production, and this is a chronic bronchitis kind of a phenotype, which is defined by your cough and sputum for 3 months, for 2 years, provided there is no eosinophilic airway inflammation and there is no other cause which can explain these symptoms. And again, you have number of drugs available: guaifenesin, carbocystine, N-acetylcysteine, and roflumilast. So those patients who continue to be troubled with sputum, they need to be treated separately with the medications to look after their sputum production and clearance from the lungs. And then comes the airway inflammation. And there is a group of COPD patients who do not have a neutrophilic inflammation, but an eosinophilic inflammation. And this we have learned from the asthma, that you can pick up them with blood eosinophil count in the COPD also, and that is why that 300 numbers have come for using ICS, but you can use a pheno, and not only ICS, but you can use in these patients what is the newer drugs which are coming up as biologicals. And we know that eosinophil numbers are like fluid numbers. Anything is higher the number, better the response to inhaled corticosteroids or the drugs which are targeting eosinophils. So 300 is kept as a number, but it's a fluid number. But beyond the inhaled corticosteroids in COPD, also with eosinophilia, is the newer biologic, and it has already done the job. Dupilumab, which is a monoclonal antibody, which is a dual blocker, which blocks the interleukin 4 and interleukin 13, because both of them have actually combining together with a similar receptor. So alpha R receptor of IL-4 and IL-13 is shared, and dupilumab goes and blocks that. So it blocks not only one cytokine, it blocks both the cytokines. And it has been shown in a duplicate 2 trials, Notrias and Boreas, where patients of moderate to severe COPD with only one additional factor, that is the eosinophilia, were enrolled in these trials. And this eosinophilia was more than 300 cells per microliter. And both the trials reciprocated the results, that not only they lead to extra 1/3 reduction of exacerbations beyond triple therapy, but very importantly improves the lung function, which is almost about somewhere around 50, 70, 80 ml. So these 2 trials, on the basis of these two trials, which are both positive, affirmative in COPD with eosinophilia on triple therapy, they have applied for the approvals for use of this drug, dupilumab, in patients with COPD, eosinophilia, continue to exacerbate on triple therapy. Moving ahead is the airway colonization and infections. These patients can be easily picked up by the sputum examinations. Now we have multiplex PCRs to pick up very quick within 2 hours. You can use antibiotics to eradicate the infections. You can use the antibiotics on long-term basis where you can suppress the inflammation, infection, and also you can take care by using various respiratory vaccinations. And then there is another pulmonary trait, which is a chronic respiratory failure. And this can be easily picked up on an ABG, whether you have an increase in CO2 or a decrease in O2, and you can give either a long-term home oxygen therapy or an NIV to this group of patients. But now comes to the second most important part of these treatable traits, that is the behavioral and risk factors which are there. And you can see that smoking and exposures are something which needs to be looked into. You can do exhaled carbon monoxide or urinary continin, and cessation, NRTs, pharmacotherapies, avoidance, all can be given to the advice given to the patients. Exposure to offending allergens and pollutions can be picked up by the AQI as well as by the skin prick and other test, and avoidance and desensitization possible. Patients who are poor perceivers, they have a mismatch between their objectives and subjective findings, and reassurance, breathing exercises and other things need to be told to them. Those who develop side effects of the drugs, you need to withdraw while monitoring these patients and optimize their therapeutics. Inhaler polypharmacy need to be reduced by not using multiple devices and rationalize your device use. Technique and adherence needs observation and education, and of course using simpler devices which the patient can use. And of course you need to have a family support and try to arrange for that. So all these parts are very important, which are the behavioral or the risk factors. But equally important are the extra pulmonary treatable traits. And you can see that patient might be having cachexia, which can be looked after, or patient can be even obese. So BMI is an indicator, and diet and physical activity will look after that. Deconditioning can be picked up on a cardiopulmonary exercise test, and rehabilitation is an answer to treat that. Obstructive sleep apnea by a polysomnography, PAP, and a weight reduction if patient is obese, but 50% of COPD patients with sleep apnea are not overweight. Cardiovascular comorbidity, ECG, echo, and these days we are all doing NT-proBNPs and BNPs, and of course there are drug therapies for that also. GORD or GERD, whatever you want to call it, upper GI endoscopy, esophageal pH monitors. If the patients are not responding to your empirical PPI, then of course you can add on to H2 blockers and do many other things to control their GERD. Those patients who have associated chronic rhinosinusitis, which can be picked up by clinical imaging, can be given intranasal steroids. And very importantly, a lot of airway patients have vocal cord dysfunction. You can pick up by FOL or a dynamic MRI and can advise a speech therapy. And finally, we have an overlap of about 20% of these patients who have psychiatric disorders, and this either anxiety or depression, which can be actually picked up or diagnosed by using questionnaires, simple 2-question questionnaires for anxiety as well as depression, psychiatric examination, and you can give them on not only the CBT but also the pharmacotherapy be offered to these patients. So this is my concluding slide, that COPD management in clinical practice, how it should look like in future. So what we are presently doing is obtaining the information from the patient, integrating into the medical history, doing their lung functions and some blood tests, and then starting them with this treatment. This ends in 2023. So 2024 onwards, what we are now expected to do is list the major traits which are affecting the patients, be it pulmonary, be it extrapulmonary, be it behavioral or risk factors, and list them which can be actually targeted immediately, which can be easily picked up and diagnosed by your clinical as well as investigational tests, and then offer the treatment according to prioritizing them, which is primarily affecting the patient. A patient who continues to cough with a chronic rhinosinusitis in COPD needs to be dealt with that first. Even it could be GERD there, which needs to be again targeted there. And other factors like social issues, family issues can be dealt later. So prioritizing those traits which needs to be immediately looked into, and then once you follow up the patient, you realize that what have been left behind, and tailor that treatment of the patient as an individual patient of COPD who continues to suffer despite your dual and a triple therapy addressing heterogeneities in COPD. So this is what we are not only learning to do, but we are also now starting to do, and definitely the future is definitely there. So we are going ahead with that. With that, I would like to thank you all. I do not know whether the things will get better if we change, but we know that we must change if we want to get better. So that is for sure. Thank you very much.
Thank you, Dr. Talva, for making us look beyond the guidelines in COPD care. It's my pleasant task to ask my co-chair to introduce our next speaker.
The
Go
next
for the questions
speaker
after the...
is Dr. Ishant Perra, Consultant Respiratory Physician, National Hospital for Respiratory Disease, Sri Lanka. He'll be speaking on new paradigms in long-term care of bronchiectasis. Over to you.
Thank you, chairpersons and the council and the president for giving me this, inviting me to deliver this talk on bronchiectasis. Bronchiectasis is an emerging global health issue and is a progressive respiratory disease. It's very likely to underdiagnose with coexisting with other diseases like the OADs, and it affects people of all age spectrum. Mainly the highest number is in the female group, more than 60. It is characterized by permanent dilatation of bronchi and presence with clinical symptoms of cough, production of sputum, and recurrent respiratory infections. With that, may progress into the decline in lung functions. And there is so much of heterogeneity in the disorder, and there is no typical bronchiectasis patient where you can apply one size fit for all. The heterogeneous nature is due to many factors, due to underlying conditions, the comorbidities, the lung function, the radiology, microbiology, the disease severity, and so on, and the treatment adherence and the social circumstances. So with that, however, common to all, there are 4 key aspects in the pathophysiology which is common to all. There is a cycle of infection, inflammation, dysfunction of the mucociliary clearance, and a structural lung damage as well. And there are a variety of potential causes, the infections, the immune deficiencies and other things the impaired mucociliary clearance in CF and primary ciliary dyskinesia and Young syndrome and connectivity disorders and ILDs, sarcoidosis and post-TB disease and foreign bodies and various obstructions and the rare other causes like alpha-1 antitrypsin deficiency and so on. But common to all, the pivotal role of infections are important. Many are thought to be due to prior infections secondary to the previous factors I have explained. And there is also a problem of persisting lung infections, which is a hallmark of bronchiectasis, which could be polymicrobial, complex and challenging to treat, and with leading to various outcomes. The most commonest bacteria are the Pseudomonas and Haemophilus as gram-negatives. There are gram-positives like Staph and Strepto and Moraxella enterobacterisi. And also there is co-detection of both aerobic and anaerobic species. There's also high incidence of non-tuberculous mycobacteria. NTMs are also related in patients with pre-existing lung diseases like in post-TB cases as shown in the US bronchiectasis registry. And also there may be NTMs without pre-existing lung disease as in older women with a predilection to the left upper lobe, the lingual segment and the right middle lobe as been described in Lady Windermere syndrome. NTMs are characterized by on HRCT bronchiectasis and pulmonary infiltrates and nodules and may be associated with progressive lung disease. So when you consider the management, the long-term goals are to treat the underlying conditions, to treat the associated bronchospasms if there are, and prevent lung infections, remove excess mucus, and prevent the exacerbation which is related to the final outcome of the disease. In the medical management, you have to confirm the diagnosis and evaluate the underlying disorders, and there should be a multimodality approach which is personalized to individual patients. So here also we, as in many other diseases, we employ the precision medicine, tailoring treatment to individual basis with the patient characteristics and specific pathogens and genetics and so on. So when you apply a stepwise approach, we need to confirm, as I said, and pay attention to the general conditions of the patient, the nutrition, healthy lifestyle, the vaccinations, and the oral hygiene. You have to clear the airways of mucus and may employ anti-inflammatory therapies, and you may need prophylactic antibiotics, and you should have some plan for your treatment for exacerbations. So in confirming the diagnosis, in evaluating this patient as precisely as an individual, not only the symptoms evaluation, the family histories, the age of onset of the disease, whether it is local or diffuse bronchiectasis, you may have to take precautions. I mean, you may have to take more information and tailor your treatment accordingly. In this clinical evaluation, the assessment of severity also will be important. There are multidimensional scores developed and validated, like phase score and the bronchiectasis severity index. The phase score, as depicted in the first letter of these factors, like FEV1, age, the chronic colonizations, the extension of the lung condition, whether it is multilobe or single lobe, or the dyspnea scale, depending on that, various scores are developed, and to which would say the progression outcome or the future outcomes of the disease at a category of mild, moderate, or severe. In the BSI, there are other things added, like BMI, the previous hospitalization admissions and the severity of admissions and so on. And again, they have developed gradings, mild, moderate, and severity, and it will give some idea about the outcome of the disease in the future. But notably, these severity scores will allow only the future risks, but will not give an idea about whether they are going to respond to specific treatments or not. So better tools need to be developed in future. In the investigative evaluation, many guidelines routinely recommend the bundle of tests for a newly diagnosed patient. But again, although basic investigations are there are other advanced tests which should be tailor-made for the patient. For example, the patient presenting with a young patient coming with bronchiectasis, you may have to go further for evaluation of the immune deficiencies and the family history, and all those factors have to be considered. The basic radiology, chest x-rays and x-ray sinuses are important. I would not go into the details. This morning we saw another speaker talking in detail about the bronchitis changes and although the HRCT findings which you expect there in a bronchitis patient. Microbiologically very important. You need to get because infections play a pivotal role here, the management and the causation of the disease. Therefore, the bacteriological cultures, sputum for TB and NTMs, gene experts and so on are very important. You need to, even if you culture an organisms, you need to analyze the extent of the infection by CBCs and inflammatory markers. You may have to compare your previous x-rays of the patients and the CTs to see whether it is just a previously known thing with the colonization or just a infection coming out, taking over the patient's condition. And bronchoscopy has an important role maybe for direct visualization and also to rule out offending causes like obstruction or foreign body. And maybe you can take very deep samples by microbiological processing. Pulmonary function tests are very important to categorize whether the patient in the severity assessment. And also, you have to tailor-made, you have these investigations in where relevant to investigate for a cause, like to identify the immunoglobulin deficiencies, the total IGs in case of ABPA, and aspergillus specific indications in parameters you may go ahead and investigate where relevant. And also, if there are clinical suspicion of autoimmune conditions, you may go for this autoimmune screening as well. And specific immunodeficiencies like complement and specific cell-mediated or humoral immunity, we have to investigate for. And nitroblue tetrasodium test, NBT for neutrophil function, flow cytometry for deficiencies in specific cell types, and also specific antibody responses to various antigens or immune vaccines like pneumococcal H influenza and tetanus. And we in Sri Lanka, we also use this post-typhoid V1 vaccination. Where relevant in younger people may employ an alpha-1 antitrypsin level, and for CF we don't see much here. CF testing for GF mutations and sweat chloride test for the same condition, and also where relevant in electron microscopy, we don't usually have it for routine care. In the pharmacological management, bronchodilators may be important because many of them are associated with airways obstruction. Inhaled corticosteroids may be useful in these conditions, but there's a possible potential harmful effect of increasing pneumonia rates and NTM infections. Systemic steroids has no long-term role. As in the previous speaker's talk, mucolytics are very important. Again, you have various oral or nebulized forms of mucolytics. Antibiotics, again, very, very important. You need to optimize the use of antibiotics to targeted approaches, considering how to differentiate between infections versus colonizations, the lung microbiome diversity, whether it is going to cause harm by giving antibiotics, and how to minimize the development of antibiotic resistance. So in this antibiotic stewardships, the 5 Ds as key elements: the selection of the right drug, the correct dose, the correct drug route, the suitable duration, and de-escalation to pathogen-directed therapy. For exacerbations, when they are present with, we select the correct antibiotic with empirical. If you are using empirically, considering the previously known organisms, the route, whether to go for oral or IV, and the duration depending on the severity of the condition. In the maintenance therapy of the prophylactic antibiotics, if there are frequent exacerbations, 2 or 3 more per year, and you have to employ targeted long-term antibiotic strategies, which may be oral or nebulized. The various forms are given in the various guidelines, but in our practice, there is so much of antibiotic misuse in common day-to-day medical care practices, and therefore, many of them may not work well in these settings. For example, azithromycin use we have been using in long term in our country for specific indications for the reduce the reinfections and the symptoms and also improve the quality of life in and non-CF populations. Nebulized tobramycin for CF and colistin and gentamicin are again may be useful. In the macrolide prophylactic therapy, this has been supported by clinical trials, whether to use 500 milligrams 3 times daily or 250 milligrams daily or erythromycin. The role is they have the direct antimicrobial effects, as also there is immunomodulatory properties of these antibiotic macrolides. There are other concerns about the macrolides, the potential for disrupting the lung microbiota and the development of resistant organisms, the adverse effects like cardiac arrhythmias and hearing losses, and monotherapy of macrolides may have an implication with if you're having co-infections with NTMs, because it's going to cause drug resistance to the NTMs. Inhaled therapy is also newer developments of given, for bronchitis patients. They could be used for bronchodilator properties and inhalation antibiotics, or maybe sputum clearing agents. And the advantage is delivering the medication directly to the site. Inhaled antibiotics may be used for pseudomonas, for gentamicin, tobramycin, cipro, and colistin. Talking back on NTMs, not all patients with NTM infections require antibiotic treatment. Treatment is warranted if the organism is persistent and causing lung damage and symptoms. Microbiology results have to be needed by, they have to be guided by the microbiology results. Most common pathogens are the MAC group and the M. abscessus. You may use various antibiotic combinations, and not only these, maybe other things as well, but usually given for 12 months until they become negative for 12 months, and generally maybe going for a longer period. Considering the airways clearance techniques, the idea is to mucus clearance. You can use mucolytics, oral or nebulized, the expectorants, and hydration, very important, because they are hyperventilating, they are dry, and clearance techniques and devices are very important. When you consider the clearance techniques, there are chest physiotherapy by clapping on the chest, by the respiratory therapist or electronic chest clappers or vest. There are breathing techniques to move mucus up to the upper airways, the forced expiration techniques, the active cycle breathing, the devices, oscillating positive expiratory pressure devices, and intrapulmonary percussion devices, and some of them are being gradually introduced in this country as well. Prevention of infections is very important by the use of prophylactic antibiotics. The oral hygiene very important. We tend to forget this because we have a population of people in Southeast Asia who are beetle chewers, having a source of infection right there at the upper respiratory tract, and regular immunizations of pneumococcal and influenza vaccinations. And also, if somebody is, whether in being, even a child present with this bronchiectasis at young age, whether the past immunization schedule have been followed or not, that has to be evaluated as well. Nutrition and hydration, very important. Issues are seen because there is a poor nutrition, the protein and energy malnutrition is there, hematine deficiencies are there, reduced bone mineral density is there in most of these females and the older people. This is due to the poor intake, the catabolism, protein losses, the secretions, and anemia of chronic disorders, and so on. Whether you have to provide vitamin D supplementation, a question to ask. They may have a role in the OADs, but whether they have a role in bronchiectasis is a question. But anyway, these patients may be vitamin D deficient. Management of underlying associated conditions are important. Quitting smoking, where relevant, there is immune deficiencies. IG may be, that is in various indicated patients. Alpha-1 antitrypsin therapy for CF patients, recombinant DNase nebulizations, and the treatment of associated CTDs and all. The oxygen therapy, there is a reduced oxygen supply because of the damage and the raised demand with the hyperventilation, and you need to assess them for suitability for domiciliary oxygen therapy for those who are having significant disability and those who are having reduction in the FEV1s and the oxygen saturation when this is low. The surgical options are there as well for local resection of very localized diseases with having problems. There is a problem of spillage over to the other parts of the lung, and which is the area which is not contributing to the lung function may be removed if the patients are suitable for a resection. Surgery also may be used for bronchitis related to NTM, which is not responding to medical management. In advances, telehealth and remote monitoring of the patient's symptoms and medication adherence and virtual consultations may be available in future, having these telehealth platforms. So finally, the multidisciplinary care is very important in managing of these patients for the collaborative care of comprehensive management involving various healthcare professionals, the pulmonologists, the therapists, the physiotherapists, and the nutritionists, and so on. And also, they are very important in the management of these patients. I did not specifically go to talk on the management of the pulmonary rehabilitation aspect of these patients because it's been dealt in detail in the morning. And also, I did not discuss about the management of the hemoptysis related to bronchiectasis because that has also been dealt in the morning. So looking for future therapies, the novel agents, they are centering around neutrophilic inflammation and treatment of the infections. There are phase 2 studies of neutrophil elastase inhibitors. Brensocatib phase 3 Willow trial, there is a new oral anti-inflammatory treatments where selective inhibitor of enzyme DPP1, which is involved in the neutrophil activation and inflammation, and is shown to be reducing the exacerbations. And also recombinant human DNase, it helps to degrade the biofilms. Biofilms are the ones, they utilize extracellular DNA released from the neutrophils in their formation. They allow bacterial communities to survive physical and chemical stresses and play a critical role in establishing the chronic infections. So it's been found in Haemophilus and Pseudomonas infections. Statins. It has been found that there is an immunomodulatory role in statins as well in the modulation of the neutrophil inflammation. There are novel antibiotics like lefamulin in phase 2 trials with promising results against Pseudomonas and also ericase. And this is a liposomal formulation of amikacin which is administered via a nebulizer. Promising results against NTM have been shown. Phage therapy offers a potential alternative for antibiotics targeting specific bacterial strains without affecting the surrounding healthy bacteria, and it has shown promise in potential treatment of bacterial infections as well. In summary, bronchiectasis is a global health issue, a highly heterogeneous disorder which is a major challenge for management. Many infections are involved in the causation, infectious agents are involved in the exacerbations, and it's a personalized multimodal approach for the care of these patients. And there are some few promising novel therapeutic agents in the horizon. Thank you.
Thank you, Dr. Ishant Perra, for this beautifully done lecture and especially for keeping to time. Thank you.
Right. It's my pleasant task to introduce Dr. Chandana Kurthanka, consultant respiratory physician from Teaching Hospital Ratnapura. Chandana has been our champion on environmental diseases, airway diseases. He has done many public education campaigns on environment days, in educating public on the hazards of both indoor air pollution, outdoor air pollution, and occupational lung diseases.
Of introduction. Good afternoon. So, my task is to discuss airway dysfunction in occupational lung disease. Within next 20 minutes, I'll be talking on the definition of occupational lung disease and the impact of the diagnosis, and then little bit of anatomy of the airways, and then I'll be talking on the occupational bronchiolitis and the occupational asthma and occupational COPD. So what is occupational lung disease? Exposure to toxic inhalants in the workplace has the potential to cause almost any major type of lung disease such as asthma, COPD, that's your obstructive airway disease, and interstitial lung disease, and even lung cancer. Apart from the onset of new diseases, the following exposure to these toxic dust and fumes, the existing lung disease will worsen. Without an awareness of the range of different occupational lung diseases that exist, their similarity to the non-occupational counterparts, and without direct questioning, these conditions may go unidentified. These workers are often in lower paid and are disproportionately affected by health inequality. Both clinical and socio-economic outcome generally improves if cases are detected early. Evaluation needs a comprehensive history, current and past occupations, home environment, hobbies, the potential for second-hand or para-occupational exposure, history of present illness, and timing of onset of symptoms are very important. So why is the diagnosis important, or implications of diagnosis of occupational lung disease? First, this allows the appropriate advice to be given about the risks of ongoing exposure, and then it's very important for the clinical management of the current disease, and then the occupational mobility. So the patient can move from the occupation to another occupation. And then the most importantly, they are eligible for legal compensations. So as respiratory professionals, it's important that those diseases are not missed. Pneumoconiosis. Pneumoconiosis is a group of interstitial lung disease caused by the inhalation of non-organic airborne dust and fibers. The most frequently encountered types of pneumoconiosis are asbestosis, silicosis, and coal miners lung. But in Sri Lanka, the silicosis is the most the common out of these three lung diseases, pneumoconiosis. So silicosis is found especially in the Matale and the Candid areas, because there are various factories which process silica. The particles cause inflammation and fibrosis in the lung, result in irreversible lung damage. So these are the causes of pneumoconiosis. Coal workers pneumoconiosis, that's due to exposure to coal dust. Silicosis, crystalline silica, and asbestosis due to the inhalation of asbestos fibers. So list goes on. And apart from the inorganic dust, so exposure to organic dust causes hypersensitive pneumonitis. So this is the list of the causes of hypersensitive pneumonitis. And you can see the following exposure to proteins in droppings and feathers, the following exposure to birds, and then the individuals will develop hypersensitive pneumonitis, and then the farmer's lung, the following exposure to the moldy hay, straw, and grain. So these are the commonest causes of the hypersensitive pneumonitis, occupational causes in Sri Lanka. So now let me discuss the little bit of anatomy of airways. The small airway anatomy. The airways consist of approximately 23 generations of dichotomously branching tubes from the trachea to the alveoli. The main functions of the airways are to ventilate the gas exchanging units of the lung, the conditioning of inhaled air, removal of particulate matters, and immune defense. The first 15 generations of airways are called the conducting airways and take no part in gas exchange. They constitute the anatomical dead space. The small airways refer to those airways less than 2 millimeter in diameter. So you can see there will be bronchioles, the proximal bronchioles, terminal bronchioles, respiratory bronchioles, and alveolar ducts. Usually the small airways are defined as the part of terminal bronchioles, respiratory bronchioles, alveolar ducts, and alveolar sacs will be your small airways. The small airways are major site of pathology in many lung diseases, including COPD and asthma. The small airways are frequently involved early in the course of these diseases, with significant pathology demonstrable often before the onset of symptoms or changes in spirometry and imaging. But this evaluation of the small airway function is relatively difficult because relative inaccessibility to biopsy and their small size, which makes their imaging difficult. Traditionally, lung function tests may only become abnormal once there is a significant burden of disease within them. Therefore, the small airways are labeled as the quiet zone or silent zone of the lung. Specialized tests have been developed to detect the small airway dysfunction, and these tests are now moving from the clinical research laboratories into routine clinical practice. So this is the histology of the airway disease, that is your bronchiolitis. Inflammation of the bronchioles may be due to infective causes or following the inhalation of toxic dusts and fumes. So there are various the forms of histological patterns of bronchiolitis. The first one, A, shows the cellular bronchiolitis, and then the granulomatous, follicular, but most important is the slide D. And slide D, you can't see the lumen of the bronchiole. So this is your obliterative bronchiolitis, and in most of the occupational bronchiolitis, you will get the histology of a obliterative bronchiolitis. Bronchiolitis is characterized by inflammation of the small airways. As I told you, they are less than 2 millimeter in diameter, and the most common clinical presentations include insidious onset of exertional shortness of breath and cough. Known causes of occupational bronchiolitis based on the published data, the published literature include flavoring-related lung disease caused by exposure to diacetyl, and then the constrictive bronchiolitis associated with military deployment. So the diacetyl is a commonly used the organic compounds to get the butter taste. So it is commonly used in most of the food industries, but it is more common in the popcorn industry. So how do you diagnose bronchiolitis? So nowadays you don't need to go for a lung biopsy, and HRCT will be enough for the diagnosis of the bronchiolitis. So there will be direct signs and indirect signs. I'm not going to discuss these things were discussed early in the morning. So direct signs will be central lobular nodules due to inflammation and the excess mucus production, tree in bud, and bronchial ectasis. Indirect signs include mosaic attenuation in inspiration, and there will be air trapping during expiration. So these are the various industries associated with respiratory bronchiolitis, and most of the studies are actually related to the popcorn production and popcorn industry. And even in Sri Lanka, I think Professor Dushanta Madagidar has published some case reports the bronchiolitis in popcorn workers. And this is Southern Asia military deployment related bronchiolitis cases. And these studies have done in the Gulf areas in Afghanistan and Iraq. And the soldiers employed in these areas have developed bronchiolitis due to the following exposure to diesel exhaust, and then the sand, and then the dust related to explosions. So now let me discuss occupational asthma and occupational COPD. So when to suspect occupational asthma? Patients of working age who presents with new symptoms suggestive of bronchial asthma, reappearance of childhood asthma, or deteriorating asthma during the working environment, and unexplained airflow obstruction in risk of occupations, then you have to suspect occupational asthma. So based on the underlying mechanisms, there are two types of occupational asthma with different clinical features. There are two main types of occupational asthma: sensitizer-induced asthma and irritant-induced asthma. So diagnosis of occupational asthma is the standard diagnosis, the methods for your bronchial asthma. They need spirometry and peak flow monitoring, and treatment is the standard treatment, but you need to prevent the exposure. Otherwise, the patients will end up with the airway remodeling and related complications. So sensitizer-induced asthma considered the most common type of occupational asthma, and it is induced by high molecular weight or low molecular weight agents. The high molecular weight agents are glycoproteins, and low molecular weight agents are synthetic chemicals. So I'll just show you some examples. And the most common causes of occupational asthma have been following exposure to these are the workers: bakers, the pizza and pastry industry, grain industry, and the I can't see actually. And then these are the sensitizing low molecular weight agents, isocyanates. These are the workers: spray painters, polythene production, plastic industry, molding, and these are the commonest occupations who are developing occupational asthma. So this is the difference between sensitizer-induced asthma and irritant-induced asthma. Usually sensitizer-induced asthma is immune-mediated, so therefore they need a latent period for them to get sensitized. And irritant-induced asthma, there will be no latency. Most of the time the symptoms are acute. In sensitized the occupational asthma, they need low dose exposure, but irritant-induced asthma, they need a very high level of chemicals for them to develop bronchial asthma. Allergic rhinitis and conjunctivitis may precede or coincide with asthma symptoms, but rhinitis, conjunctivitis, corneal ulcers, and pharyngeal erythema may occur following high dose exposure. Atopy is a risk factor for sensitizer-induced asthma, but atopy is not a risk factor for irritant-induced asthma. Occupational COPD. So according to the literature, about 25 to 30% of patients with COPD are never smokers. Now, this is considered as a different phenotype of COPD, and this is thought to be due to environmental and occupational exposure or due to maybe the childhood infections. In the mid-19th century, John Hutchinson, the inventor of the spirometer, had already noticed different vital capacities according to height, age, and occupation, and encouraged public health and statistics experts to conduct studies to confirm the influence of both trade and the locality on respiratory health. Subsequent landmark publications established the role of occupational exposure to dust and the COPD. So, the occupational exposure with stronger evidence of association with COPD include coal mine dust, silica, grain and textiles, agricultural dust, and asbestosis. So there are enough epidemiological studies which links COPD to indoor air pollution and outdoor air pollution. And apart from the onset of COPD, the existing COPD will become worse following exposure to the toxic dust and fumes. Now let me conclude my talk, leaving you the take-home message. The occupational lung diseases are under-recognized, especially in resource-poor countries. They cause airway disease, interstitial lung disease, and even lung cancer. The diagnosis of occupational lung disease allows appropriate advice to be given about the risk of ongoing exposure, clinical management, and compensation. The airway dysfunction is common. Small airways are involved in popcorn industry, and soldiers exposed to dust in Gulf area result in occupational bronchiolitis. Inhalation of inorganic dust, the silicosis, the black lung disease, and the hypersensitive pneumonitis following exposure to organic dust is associated with small airway dysfunction. Understanding of work-related asthma and COPD is important to improve the quality of life and to prevent the disease-related complications. Occupational and environmental medicine is a unique preventive specialty that positively impact the health and productivity of workers and therefore the health of national economies. Thank you.
Thank you, Chandana, for those valuable insights given into an often neglected group of lung diseases. We'll keep the question for when we finish the session.
Ladies and gentlemen, the next speaker is Professor Anup Chauhan, the respiratory physician from United Kingdom, and he'll be speaking on management of CV asthma, what is new.
The journey of research and innovation in asthma over the last half century or so has significantly shaped the way we approach this challenging condition. We'll start by reflecting on the landmark developments, beginning with the introduction of Ventolin in the 1960s, and we saw the advent of inhaled corticosteroids in 1972, and in the 1990s we saw the first iteration of the Global Initiative for Asthma Guidelines, which set a new standard of managing asthma across the world. The turn of the century then marked a significant leap with the introduction of biological therapies, which have changed the game for those with very severe asthma. This era also saw the combination of inhaled corticosteroids and long-acting bronchodilators, improving the control and convenience for many patients. In 2016, we saw the concept of treatable traits, which signaled a move towards a more personalized precision medicine approach, which has evolved since then, and that's helped us increase the understanding that asthma is not a one-size-fits-all condition. So our practice in severe asthma now integrates all of these past lessons with the latest advancements to forge a pathway in severe asthma management. The focus of our discussion, therefore, will be on exploring the following 9 areas of new developments in asthma that I'd like to share with you today, beginning with what is defined as severe asthma, and also talking more around the personalized approach to asthma, the role of biologics in asthma, and then also the importance of the organization of care in order to bring all of this together. So what do we define as severe asthma and what are its impacts? According to the ATS-CRS guidelines, severe asthma is one that has been confirmed objectively using physiology and spirometry and with the presence of inflammation, where the comorbidities are optimally managed, where the adherence is confirmed, and also the treatment is optimized for at least 3 months under a specialist care. This can then escalate into established severe asthma if it remains uncontrolled, despite high-dose inhaled corticosteroids and the second controller. And we define uncontrolled using a series of criteria which indicate poor symptom control, frequent exacerbations, serious exacerbations escalating to hospital or ICU stays, and with persistent airflow limitation, and also rapid deteriorations on reducing the inhaled corticosteroid dose. The burden of severe asthma is substantial, not only in terms of health, but also in its socioeconomic impact. Patients experience a significant decrease in their quality of life, demonstrated through persistent debilitating symptoms, more frequent exacerbations, and a fast decline in lung function, and a higher risk of side effects from treatment as well. And we also recognize that the management of severe asthma is notably more costly due to the increased healthcare utilization associated with severe disease, with high-cost medications contributing to about at least 40% of the overall cost. Also pertinent is that those with the very most severe asthma, those 10%, will also consume nearly 40% of the total health costs for asthma. It's therefore important to recognize those very severe symptoms in order to have the maximum health economic impact. So in the chart above on the right is a mortality risk stratified by GINA asthma stage from a cross-section study. It shows that the highest risk is as expected in stage 5, but also note that increased risk at stage 1, often because patients are unrecognized as having at least moderate to severe asthma, and therefore they don't get access to the right treatment. So our aim in managing severe asthma is not only to control the symptoms, but also prevent exacerbations and to minimize these broader impacts. Moving on to the pathophysiology of severe asthma, it's essential to understand that this is not a uniform disease, but rather a complex syndrome characterized by chronic airflow inflammation and a range of pathological features that are illustrated in these figures. The hallmarks of asthma in terms of airflow obstruction, bronchial reactivity, and inflammation are characterized by the key inflammatory cells and cytokines that propagate these processes as shown here, and therefore it can lead to an array of pathological effects that can occur in the asthmatic airway shown on the right-hand side compared to a much more healthier one on the left-hand side. We can measure the effects of asthma using a variety of tests at our disposal, from simple bedside tests to much more nuanced tests that will give information on the triad of asthma, its effects on the airway, and also the presence or absence of comorbidities. Variable airflow obstruction, we can use by standard lung function tests. We can measure bronchial hyperreactivity by sensitivity of the airways to various stimuli such as methacholine, and then we can map A to P by simple skin prick testing or measurement of IgE levels. Inflammometry is a term that encompasses these various measures of airway and systemic inflammation, and we can use simple blood eosinophil counts, the fraction of exhaled nitric oxide, and where available sputum cell counts to define the level of airway inflammation and responses to treatment, but also recognizing comorbidities using questionnaires such as sinus disease, gastroesophageal reflux, obesity, the psychological stress, anxiety, and depression is important to recognize through questionnaire assessments, as that may also complicate management. And therefore, a comprehensive approach that addresses these factors is vital in the management of severe asthma. In this section, we see that the new GINA guidelines have made several recommendations. What has been retained is a 5-stage escalation, which recommends increasing treatments based on increased symptoms and the effects on the individual, from step 1, which is very mild asthma with infrequent symptoms, to step 5, which is very much more severe disease requiring high-dose anti-inflammatory therapies, other controlled medications, and consideration of biologics. However, what is new is that there is a new track 1 approach using a combination of ICS and formoterol at steps 1 and 2 as the preferred regimen for asthma management. The escalation for the other steps remains the same. So this recommendation of using ICS and formoterol early is underpinned by robust evidence supporting the effectiveness and safety of this combination compared with the use of SABA alone or with low-dose ICS. What is also retained is the approach around managing patients in terms of assessing their response to treatment, adjusting it, and reviewing it as well. So why have GINA guidelines chosen to have a variation at steps 1 and 2? And that's because the literature supports the superior efficacy of the combination of ICS and formoterol in managing asthma symptoms and reducing exacerbations. A Cochrane review in 2021 encompassed 4 12-month studies involving around 10,000 patients, which solidified this stance. On the other hand, the evidence for as needed ICS-SABA is limited, with only one 6-month RCT with 455 patients showing effectiveness. So the evidence becomes even more compelling at steps 3 to 5, where maintenance and reliever therapy or MARCH treatment regimens significantly outperform those with as-needed SABA. And this is supported by extensive data from over 30,000 patients in various studies. Also, both the anti-inflammatory effects of ICS and bronchodilator action of formoterol contribute to this reduction in severe exacerbations, as shown in studies by Tattersfield, Powers, and Bradley et al. So the safety of this approach has been established in large-scale studies, which indicate that up to 12 inhalations per day in this approach can be taken safely in any single day. So the key advantage of having this combination of ICS and formoterol is that its simplicity. It benefits both patients and clinicians. It involves a single medication for both symptom relief and maintenance treatment, starting from diagnosis, and avoids the confusion of an inhaler technique with multiple different devices for patients as well. Where there's a short-term increase in symptoms, patients can simply increase their as-needed doses, so treatment can be stepped up or stepped down by adjusting the number of maintenance doses, allowing for a much more flexible, patient-centric approach to asthma management. Let's now consider personalized medicine in asthma, which is a critical advancement in our therapeutic approach. So patients with asthma will often present with complex breathing syndromes that constitute multiple overlapping conditions, each contributing to the overall symptom burden. So understanding this complexity is crucial to delivering effective personalized care. And these will be manifest as shown here by different clinical expressions, pathophysiological processes, physiological impairments, and behavioral outcomes, which ultimately lead to different treatment responses and prognosis. So here we recognize phenotypes in asthma as defined by the observable characteristics of individuals resulting from the interaction of the genotype with the environment. Identifying phenotypes is key in guiding targeted treatments, as different phenotypes will respond differently to various therapeutic approaches. Biomarkers add to the armamentarium, such as blood and sputum inflammatory cell counts, total IgE, and fractional exotic nitric oxide levels, and these objective measures can indicate the presence or absence of inflammation. Endotypes are then those pathological processes that underpin these phenotypes as well. Also, when considering comorbidities, we see a wide range that can influence asthma control and exacerbation risk. This includes reflux, obesity, laryngeal obstruction, sinonasal disease, sleep apnea, and also fungal sensitization. Therefore, as shown on the figures on the right, any one patient will have a differential and variable combination of risks, pathology, and biomarkers that will determine their treatment responses as shown. So to summarize, personalized medicine is not just about the right drug for the right patient, it's also about considering the totality of the patient's circumstances, from their biomarker profile and comorbid conditions to their lifestyle and behavior, in order to optimize asthma control and improve their quality of life. Therefore, understanding the type 2 inflammatory pathways in asthma is critical for personalizing treatment strategies. T2 high asthma is characterized by an eosinophilic inflammatory pattern that is often associated with allergy or an allergic predisposition, as seen on the left-hand side of this figure. It can also occur by non-allergic mechanisms, as shown on the right side of the figure. Currently, we don't have any biomarkers that differentiate between allergic and non-allergic eosinophilic inflammation, other than the presence of high IgE. This pathway involves key cytokines such as IL-4, IL-5, IL-13, which contribute to IgE production and eosinophil recruitment and mucus hypersecretion. So these effector cells such as eosinophils, mast cells, T2 helper cells, they all play a pivotal role in this response, which can then be triggered by environmental allergens. In contrast, T2 low asthma, as shown on the right, doesn't typically involve these allergic pathways and may be less responsive to steroids, as shown in the figure on the right. Phenotype is more heterogeneous, with neutrophils often having a predominant role. T2 low asthma can also be triggered by viral infections, pollution, stress, and smoke, with key mediators including IL-17 and also IL-8, and those drive a distinct type of inflammation that involves other cells, such as Th17 cells and innate lymphoid cells, or ILC2 cells, as shown in the figure. So it's important to identify these pathways in individual patients because it can influence the treatment choices. So for T2I asthma, biologics that target IL-4, 5, 13, and TSLP recently can be highly effective, whereas T2 low asthma might require alternative strategies such as targeting neutrophilic inflammation or addressing specific triggers, as shown on the right. So in conclusion, the heterogeneity of asthma underscores the need for precise identification of inflammatory pathways and therefore to tailor treatment. The significance of the T2 high pathway lies in its significant association with more asthma-related outcomes, poorer outcomes, including exacerbations, symptom control, and reductions in lung function. So we now recognize that biologics have revolutionized the treatment landscape for severe asthma by specifically targeting the T2 inflammatory pathway. This pathway, as described, can be driven by both allergic and non-allergic mechanisms, as we just described. So biological therapies such as mepolizumab, breslizumab, pembrolizumab, dupilumab, and the more recent tezepelumab have been designed to interrupt this pathway at various points, providing a targeted approach for patients who have a T2 high phenotype. So the efficacy of these biologics is reflected in the ability to reduce exacerbation rates and also oral corticosteroid use, and also improve lung function and asthma control, and improve the asthma-related quality of life. The National Institute for Health and Care Excellence, or NICE, has set out specific criteria for use of these treatments as shown in this table, which includes a high eosinophil count, a history of multiple exacerbations, and a dependency on oral corticosteroids. So the decision to initiate biologic therapy should be based on a comprehensive evaluation of these factors alongside their biomarker stratification. So this approach ensures that we are selecting the right patients for the right treatment, maximizing the potential benefits, which then becomes more cost effective. So it's also worth noting that not all patients with severe asthma will have a high T2 phenotype, and therefore biologics may not be suitable for everyone. As we move forward, it is likely that more biological therapies target different inflammatory pathways, which will become available. A really new treatment development here has been tezepelumab, which is indicated based on the number of exacerbations that patients may experience and having severe asthma, but it doesn't require stratification by eosinophils. So this is a key advance and also will help us in treating some individuals with potentially T2 low asthma. So significant advances have also been made in inhaler technology, as shown here, specifically the development of what we call smart inhalers, which have emerged as a key tool in managing asthma, particularly severe asthma, by reducing the potential for non-adherence. So smart inhalers are enhanced inhalers that are equipped with an electronic monitoring that automatically records data on medication use, and then sometimes provides feedback to the individual on the correct use as well. These devices can be synced with mobile apps to track dosage, frequency, and technique, which can all obviously be crucial for effective asthma management, and is shown in the figure on the bottom left. The link to cloud-based services provides further bespoke interventions and much more longer-term observation over patients' trajectories to chart their progress of the disease. So a variety of smart inhalers exist, as shown on the table on the right. Propeller Health, for example, offers a platform that attaches to existing inhalers to monitor usage and provide feedback via mobile app. This data can be shared with healthcare professionals to tailor treatment plans and identify patterns related to asthma control. AstraZeneca's and Teva's inhalers include features for dose tracking and reminders, which can then help patients adhere to their medication as well. So inhaler adherence is a significant challenge in asthma management that may be reconciled by use of smart inhalers, and this was first recognized by Hippocrates centuries ago, and the reasons for which are multifactorial, but hopefully digital smart technology may help alleviate some of this. non-adherence, as we know, can lead to poor asthma control, increased exacerbations, also higher healthcare costs as well. And smart inhalers help address this by providing reminders and tracking usage, which has shown to improve adherence. A note also about bronchothermoplasty, which has been a groundbreaking procedure, but now not so new, but it's meant for patients with very severe asthma who do not respond well to pharmacological treatments. The Airway bronchothermoplasty system shown here is specifically designed to treat airways with a diameter between 3 to 10 millimeters that extend beyond the main bronchus, and the emergence of biologics, however, has meant that it hasn't led to its widespread use, but in some patients who do not respond to biologics, it can be a useful treatment option. The treatment consists of 3 sessions, with each session lasting about 45 to 60 minutes, and there should be at least 3 weeks between each session. The procedure uses controlled thermal energy delivered to the bronchus to reduce the amount of excess smooth muscle in the airways, given that asthma is effectively a muscular disease, which is then associated with a degree of airflow constriction. So the benefits of thermoplasty have been documented in several studies. They include a significant reduction in asthma exacerbations, significant improvements in asthma-related quality of life, and also significant improvements in post-bronchodilator FEV1, but also reduction in healthcare usage, especially hospitalizations related to severe exacerbations. When that's wrapped up in a health economic sense, it has been shown to save on average about nearly $6,500–7,000 per patient, indicating not only generally its clinical efficacy, but also its health economic benefits as well. A key challenge in managing severe asthma is to identify appropriately groups of patients that will respond best to care, shown in this figure on the right. In addressing the organization of care for severe asthma, we must recognize that identifying the right patient groups for existing and novel therapies is a key challenge. But it's also equally important to identify patients with poorly controlled asthma who might not see a specialist early as well. So this requires a much more broader approach, with the end goal to ensure that each patient receives the most effective and appropriate therapy. So this requires a clinical assessment that's comprehensive. It includes symptoms, lung function, and response to current therapies. It requires biomarker analysis. It requires therapeutic monitoring responses, and most importantly, requires a multidisciplinary approach, a collaboration between pulmonologists, primary care physicians, nurses, and also asthma educators, and also using digital tools to educate patients as well and keeping them engaged. And then it requires a period of observation where we can map the healthcare utilization, and also using technology, including smart inhalers and telehealth as well, and which can then incorporate to ensure that patients receive the right level of diagnostic approaches, but also the right treatments. And we have demonstrated the benefits of using such an approach, confirmed with some recent publications as shown on the figures on the left. So as we move towards an era of precision medicine, it's clear that the way we organize care for severe asthma must evolve too. By adopting these broader strategies, we can hope to deliver much more personalized, effective, and efficient care to those who need it most. We have seen the advent of artificial intelligence across many aspects of society and medicine, and asthma is no different. And in this example, AI was compared with the interpretation of lung function tests in this landmark study published in the ERJ a few years ago. It revealed that AI provided a much more superior and more consistent interpretation of lung function tests compared to a wide range of pulmonologists. Clearly, essential lung function is important in the diagnosis and monitoring of asthma, and this was a comparison between AI and pulmonologists using a gold reference standard of 3 specialists who had much more richer information in order to evaluate whether the diagnosis made at baseline between pulmonologists and AI was the correct one. And as you can see in these figures, that AI won hands down across a variety of aspects of outcomes. So recognizing that AI not only may have a role in integrating lung function, but you can imagine that we can then begin to link this to clinical data, genomic information, and then use that to embrace AI in a much more wider sense. It can be used in mobile applications, predictive analytics, natural language processing, and also clinical decision support as well. So embracing AI could mean enhancing our diagnostic and predictive capabilities. However, we must also ensure that we maintain the human touch insist that's so crucial for patient care. So in conclusion, we've galloped through what's new in the management of severe asthma, and today's discussion has highlighted the significant understanding in asthma demonstrated by a shift towards much more personalized, targeted therapies that offer hope to those affected by this condition. We've seen asthma management evolve from a one-size-fits-all to a nuanced understanding that recognizes heterogeneity. We've seen the introduction of biologics targeting specific inflammatory pathways. We've seen the role of artificial intelligence in refining diagnostic accuracy and predicting exacerbations. Our challenge, however, moving forwards, it'll be to continue to refine these approaches to ensure that they're accessible to those who stand to benefit the most. This will require an ongoing collaboration between clinicians, researchers, patients, and healthcare systems to navigate the complexities of severe asthma care. In closing, I invite us all to embrace these advancements with a commitment to continuous learning and improvement, and hopefully we can all significantly improve or impact the lives of patients with severe asthma. Thank you.
Thank you, Professor Chauhan. And the session is now open for questions. And Professor Chauhan will be available online for the answering as well. So it is open for questions.
Okay. There. Yes. Is Professor Chauhan is available online?
Hello. Yeah.
Yes, he is.
Dr. Chauhan, can you listen to me?
Yes, I can hear you loud and clear.
Okay. Good morning.
Good morning.
So I just had a query actually in my mind that, Boston has withdrawn thermoplastic catheters, at least for our part of the country, that's India. And we have been dumped with this technology with the huge costs. So I have been, trying to, see that if it's like they're selling it to somewhere or other countries, it is still, or they're just finishing their stocks. So what is the situation of bronchial thermoplasty vis-a-vis the Boston's, I think they have given a clear directive that they're withdrawing this completely by 2024 end all across the world. So where does this technology see in future?
Thank you. It's a good question. Biologics have superseded bronchial thermoplasty, which is the reason why it is generally being withdrawn. However, in the UK, it's not such a big problem because there's only about 8 centres in the UK that have been licensed to provide this treatment. For the foreseeable future, they're continuing to do that until, obviously, the stocks and the equipment is withdrawn. For now, in our experience, first-line treatment is biological therapy, and then there are a few patients who, for one reason or another, are unsuitable for biologic therapy or who have failed biologic therapy, and those are largely those individuals with very established severe obstruction from childhood who don't have an overwhelming T2 phenotype, who might have had their treatment initially, which has not responded, and they do reasonably well for bronchial thermoplasty. However, with bronchial thermoplasty, even with treatment, the effects after about 2 or 3 years are less longer lasting. So in our experience, it is a treatment that's available for a minority of patients, but you're absolutely quite right. I don't think it has a future role, not in the face of new biologic therapies.
Dr. Advan, you have a question, right? You have a mic.
Yes, my question is from Professor Anup Chauhan. This is regarding the difficult to control asthma. Most of the biologics are validated for exacerbation-prone asthma phenotypes. So in patients with difficult to control asthma who have disabling symptoms but not having exacerbation, is there any biologics, especially the eosinophilic phenotype, is there any biologics available?
It's a really good question. Most of the biologics have been studied in patients who have had frequent exacerbations that require oral corticosteroids. So just in terms of controlling symptoms, there isn't any good evidence. I mean, those individuals who have exacerbation-prone asthma often have uncontrolled asthma from a day-to-day period, and those are the ones who are likely to benefit. But non-exacerbation-prone but poorly controlled asthma, biologic therapy is generally very expensive. Certainly when NICE have evaluated this, they've set down criteria such as the use of maintenance oral corticosteroids and the number of exacerbations. Now, in clinical practice, exacerbations are quite different from one patient to another. We often find that those with an asthma action plan, those with a predominant T2 phenotype, respond very well to steroids. And therefore, when you're setting an action plan, whereas in most guidelines, the 30% or 40% reduction mandates oral corticosteroid use, in T2 individuals, they tend to have more poorly controlled symptoms, and therefore setting a slightly lower threshold where they may benefit may actually help tease out those individuals who are probably having frequent milder exacerbations, who may then be eligible for biologic therapy. So in that situation, I would suggest that you scrutinize very carefully your patient's trajectory and see how many times they're having uncontrolled symptoms, but whether they're having peak flow reducing periods as well. And if they do, I would call them exacerbations and treat them with steroids, and therefore potentially making them more amenable to biologic therapy.
We have about 4 minutes. Is there any questions from the audience?
So, yes. So, in my understanding that in your practice, I gather from my colleagues that in your practice, I gather that you have been using triamcinolone in selected patients as an alternative to systemic steroids. What is the justification for that use?
It's a very, very good question. I think before biologics were more widely available, we recognized that there were a lot of patients with a T2 phenotype for whatever reason who were either non-adherent with steroids, had side effects, reflux and other things, did very well with a bridging treatment with triamcinolone. We certainly don't use triamcinolone as a longer-term therapy, but only in select individuals as a bridging treatment. Now, the bridging might occur because they may be non-adherent with in-house steroids, may have side effects, or even with oral steroids. So we use that as almost as a window of opportunity for us to try and work on factors that might be contributing to their non-adherence. But in this day and age, certainly our practice now has changed, is that we don't use as much triamcinolone. We transition directly to biologic therapy.
Would addition of, so one more question. So would addition of tiotropium would benefit patients who don't have airflow limitation on the spirometry? And the step 5 management of the asthma, would the addition of tiotropium benefit patients who don't have airflow limitation on the spirometry? Asthmatics with no airflow limitation on the spirometry.
Yes, that's a very good question. They do, and there is evidence to show that LAMA can also reduce exacerbations as well as improve peak flow. So if you have individuals who don't have persistent established airflow obstruction, trying LAMA in those patients is still a very useful thing to do.
I think we can take one more question. If I may.
So one more.
You want? Go ahead.
So one question from Dr. Deepak Dalfar. So this is regarding the, so I missed your talk on the COPD, but this question is that most of the evidence that we practice for the COPD are available for the, mainly done on the smoking related COPD. So is there any studies which compare the efficacy of ICS LAMA-LABA inhalers, which is especially done in India, which assess the efficacy of ICS LAMA-LABA inhalers in non-smoking COPD? In Sri Lanka, the 60% of the COPDs are not related to smoking.
I think in India, we are akin to what you said, that we roughly estimate about 50% smoker and 50% non-smoker COPD, and biomass fuel is the one which is mostly responsible. But of course, air pollution, nobody can doubt about it. Where I come from, 400 to 500 AQI, I don't think so that it can protect the lungs, and he will vouch for that. Yes, there are studies. The studies did show that this biomass fuel particularly, because it has got so much of particulate and non-particulate toxic material, it is causing, rather than neutrophilic, more eosinophilic response in the airways, and it has been shown to be having a little higher FeNO values. And the studies which have been done from the Pune group actually showed that they are more responsive to inhaled corticosteroids. So I think this is the only group in which, as per goal now, we don't have any ICS-LAVA combination up front in COPD. This is the only group in which we do consider, particularly ladies who are in the age of about 40s to 50s, who have used biomass fuel for about 20 years. They are the ones who are showing this phenotype of COPD again, which is more eosinophilic, and upfront treatment of inhaled corticosteroid is what we are using there. So I do not know how the situation is there, whether it is the same cow dung which is used as a biomass fuel for the kitchens, although it has substantially reduced in the last 10 years in India, but still, by and large, it's a major factor.
And thank you very much. And we can't take any more questions. The session comes to an end. And thank you, the resource persons, for an interesting set of lectures.
Thank you, speakers, for the insightful series of presentations. Now I cordially invite the chairpersons, Dr. Amita Fernando and Dr. Upul Dissanayake, to present the tokens of appreciation to the speakers. First up, I invite Dr. Deepak Talwar. Dr. Ishant Pereira. And Dr. Chandan Kulutunga. Next up, I invite Dr. Vatsala Gunasinghe, Treasurer of the Sri Lanka College of Pulmonologists, to present the tokens of appreciation to the chairpersons. Thank you very much. And with that, ladies and gentlemen, lunch will now be served.